Hello and welcome everybody. Thank you for joining us today. My name is Lori Gaventer and I'm a program manager at the Brown University School of Professional Studies. We are thrilled that you've chosen to participate in this masterclass on AI and healthcare opportunities and risks. At the School of Professional Studies, we hope to be your partner in overcoming your leadership challenges now and in the future. The School of Professional Studies is one of Brown University's 4 schools, in addition to the graduate school and the undergraduate college and the medical school. With its origin dating back 3 decades, it was established with the purpose of enhancing the university's impact in the world by reaching new communities of learners at all career stages through distinctive degree and non-degree programs aligned with Brown's academic strengths. We offer a variety of programs tailored to your career stage, whether you're just starting, mid-career, or at senior level. We have professional degree programs in healthcare leadership, technology leadership, and the IE Brown Executive MBA. We also offer more than 30 early career master's programs spanning leadership, sustainability, healthcare, coaching, and applied AI and data science. We offer non-degree executive education and professional certificates. And we also design custom programs for organizations. Our delivery formats include online, in-person, and asynchronous options. I'd like to tell you a little bit more about some of our programs that you might find especially relevant. The Master's in Healthcare Leadership is a 12-month master's degree program designed for professionals across the healthcare industry. The MHL is hybrid. There are 3 one-week in-person sessions right here at Brown in Providence, and the remainder of the coursework is completed online. MHL graduates have reported impressive outcomes. 60% were promoted to VP or C-suite positions, 67% reported a significant salary increase, and 73% received a managerial level position. Sandy Ferretti, the program manager for the MHL, will be facilitating the Q&A session today. I'd also like to tell you about the Master's in Technology Leadership. That's also a 12-month hybrid program with 2 4-day in-person sessions at Brown. The remainder of the program is offered online. The students come from a wide array of sectors, including insurance, defense, consulting, sales, government, and healthcare. Students work at a variety of companies, including Google, Dell Technologies, and Amazon. The MTL graduates also have reported impressive outcomes. 84% were promoted within 1 year of graduation, 48% were promoted while still in the program, and 24% were promoted to VP or C-suite positions. In addition to these 2 master programs, we also offer non-degree programs in AI that you might find relevant. So there are 4 programs you might find especially relevant. In AI Business and Leadership, you would learn how to integrate AI tools into your organization's business strategy to improve your outcomes. You would set KPIs and complete a capstone project to apply your learnings to work. The next cohort starts on June 3rd. In Applied AI and Data Science, you'll gain the technical acumen to build and deploy AI and data science models for better decision making. This is our most technical of the AI classes, and our next cohort starts on April 1st. In Effective and Ethical AI, you will learn to foster a collaborative human-AI culture to enhance, not replace, human capabilities by using these new technology tools. Our next cohort starts on March 17th. And lastly, you can take a 1.5-hour workshop to build tangible strategies to use generative AI to enhance your productivity and innovation, and that starts on April 17th. So now, let's get to our program. But first, a couple of housekeeping notes. We have 1 hour together today, with most of our time devoted to the content of our session, followed by about 10 to 15 minutes at the end of our session for Q&A. Please use the Q&A link at the bottom of your screen to post questions for the speaker. There's also a chat feature, which you should not use for Q&A, and that's available for you to post comments or to respond to any questions from the speaker. And now, I'm so excited to introduce Tom Davenport. Tom is the President's Distinguished Professor of Information Technology and Management at Babson College, the Bodley Bicentennial Professor of Analytics at UVA Darden School of Business, Fellow at the MIT Initiative on the Digital Economy, Senior Advisor to Deloitte's Chief Data and Analytics Officer Program, and Visiting Professor at the Brown University School of Professional Studies. Tom has been named as one of the top 25 consultants, one of the 100 most important people in the tech industry, and one of the top 50 business school professors in the world. He has written 25 books, more than 300 articles for the Harvard Business Review, and hundreds of other articles and blog posts. He has consulted for numerous companies and has directed research centers at Accenture, Ernst & Young, and McKinsey. His most recent books are All In on AI and All Hands on Tech, the AI-Powered Citizen Revolution. Without further ado, here's Tom.
Thanks, Lori. Very happy to be doing this session with you. Thanks for all of you who tuned in, and thanks to Brown for orchestrating everything. I'm going to be talking, of course, about AI in healthcare, and let me share my screen here. Okay, Zoom thinks that participants can now see my application, so I hope that's true. Um, just to tell you a little bit about my own background, I have been involved in AI twice, once when it was big back in the 80s and early 90s, and now again when it has become even much bigger over the last decade or so. I've written 7 books on various aspects of AI now. One on AI in healthcare called Advanced Introduction to AI in Healthcare. Um, I I think I work across industries. I work with a lot of non-healthcare businesses, but my heart belongs to healthcare, and I'm really devoted to following and talking about AI developments in healthcare. Um, I hope that you find this information useful, and I hope that you have some interesting questions or comments that we can discuss. Um, so just to give you a broader perspective on where the world of AI is in large organizations, surveys suggest that now with generative AI bumping up the numbers, 80 to 85% of large companies are doing something with AI. Um, a few of them are all in. I wrote a book a couple of years ago called All In on AI about companies that are really aggressive in their use of AI, but most are still experimenting. In general, there's been a challenge getting systems into production. It's much easier to do these proofs of concept or pilots than it is to do production deployments for organizations. And again, more tactical than strategic use of AI. A lot of companies using it to speed up a little bit or lower costs in something they do already, which I think is a bit unfortunate. Um, Automation of jobs is growing, but slowly. And so far, I think we haven't seen large scale job reductions because of AI. Low-hanging fruit tends to win out over moonshots. That's true of most technologies, of course. Um, we had in healthcare, we had very visible and aggressive initiatives like IBM's Watson for healthcare, supposedly going to treat or maybe even cure cancer, but did not really work out as planned. Um, there's been a slow movement toward democratization of data science and automation. And in healthcare, you tend to see, particularly in healthcare research institutions where people have MDs and PhDs and so on, you tend to see a lot of sort of citizen activities, citizen data science, citizen AI development activities. But again, that's slow as well. A lot of it's still centralized in technology professionals. Healthcare AI, to sort of sum everything up in one sentence, um, strong from a research perspective. Every day you read about findings that AI can do as well as or better than humans, physicians in various aspects of healthcare. But if you were to check into even quite sophisticated hospitals, I mostly am in Boston. We have Mass General, Brigham and Women's, very sophisticated hospitals, always ranked very highly. Chances are pretty good you'd see no evidence of AI whatsoever during your stay there. I did see it, I'll talk about this later. I did see it at my general practitioner, my primary care physician, last week for the first time, but still pretty rare and not really changing care dramatically at this point. I think it's fair to say. We'll talk a little bit about why. Um, I think it's also important to talk about the fact that lots and lots of investment going into AI in all large organizations these days. This is a survey that I participate in with a guy named Randy Bean. Um, uh, Global survey, 102 large organizations, some in healthcare, but mostly not. Um, a lot of organizations saying we're investing, this is really important to us. We're starting to get business value, which is a good thing. That was not true a few years ago. We've appointed a chief data officer, chief data and analytics officer, chief data and AI officer. Um, Culture, however, has lagged a bit. I mean, this was interesting because this survey has been going on for a long time. And normally, the percentage of organizations saying they were data driven or they had a data oriented culture was in the 20s. Last year, 2024, it was almost half, a big increase. And Randy and I attributed that to generative AI, really starting to get people excited about AI and making data-driven decisions and so on. This year, it fell back sort of halfway in between the historical average and last year into the mid 30s or so. So I don't know if it'll continue falling, but still we have a long way to go. And I think one illustrative survey question is we ask these respondents, okay, what's holding you back? What's keeping you from becoming data driven? Is it technology or is it people, process, culture, organization? 91% say it's the human side of organizations that are holding them back and not the technology. So, a friend of mine has a general rule: technology changes rapidly, organizations change slowly, and it's particularly true in healthcare, for better or worse. Um, what do we mean by this idea of being all in? Sort of, putting all your chips on the table, using AI across the company, both in terms of breadth, but having lots and lots of use cases. Some organizations I've researched have thousands of systems in production deployment. They're using AI not just to tinker around the edges, but to reimagine how they do their work. Lots of employees fluent in AI and how it can be applied, both users, if you will, citizens, to use that term, and also, AI professionals, data scientists, et cetera. You need a lot of high quality data to do well, whether it's unstructured data for generative AI or structured data for what I call analytical AI. Need to make a long-term commitment, spend a lot of money. Some organizations in the billions, mostly large banks, are at that level. A framework for how to make sure this is all ethical and trustworthy, and a process for applying that framework, and then a well-defined organizational structure for governing how you do this stuff. So those are some of the attributes of organizations that are all in. And in this research, we've sort of found three different objectives: creation of something new, a new business model, a new product or service; operational transformation, not just operational improvement, but really transforming how work is done; and then new customer behaviors. Sadly, we're quite familiar with how social media AI has changed customer behaviors, making us, more divided, less likely to get along or be interested in what other people have to say. But in healthcare, there are more positive things to be done. And all of my examples in that category of new customer behaviors related to healthcare. So some examples of some all-in companies that were described in this book. Elevance Health, if you're confused, it's a former Anthem, which is a former WellPoint, second largest payer after United Healthcare. They had a goal. I think the goal may have changed a bit a few years ago, to become a digital platform for health. Instead of assembling a lot of clinicians, as for example, United has done, they wanted to connect their members to needed health services and, be a platform in that sense. They did stand up a new company called Hydrogen Health to create a symptom checker app. These are, I think, increasingly common. They had one. They partnered with another organization for kind of behavioral economics type nudges to people improve their health behavior. These payers have been around for a long time. They have a lot of legacy applications, and they had a series of plans to update their legacy applications and reduce technical debt. They wanted to automate 50% of their work task over 3 years. I don't know whether they've achieved that or not. I'm not sure they're even measuring it, but that was the objective. They created a provider platform with AI in the clinical workflow, which is a challenge in general for AI, getting it into the clinical workflow. And they've saved hundreds of millions in fraud, waste, and abuse from AI, from using AI to identify fraud, waste, and abuse. So a lot going on. Still, I think some more transformations to be made. Um, uh, Over in Asia, I don't know if you're familiar with this organization, Ping An. It's the largest private sector company in Asia, only founded in the late 1980s as a property and casualty insurance company. But healthcare is one of their primary businesses. They call them ecosystems. And just to say a few words about their healthcare ecosystem, they developed an intelligent telemedicine system called Good Doctor. Um, it has over 400 million users, believe it or not, way more people than we have in the United States. Um, it does things like pre-visit triage to see if you need to visit the doctor's office. It'll give the doctor an initial diagnosis and an initial treatment strategy. They can, of course, override that if they choose to, but it saves them a lot of time in many cases. And it even will ship drugs to your home, your prescription drugs to your home. So really popular. Unfortunately, we don't really have anything that is like this in North America, certainly not in the US. I don't think in Canada either. We could use it, like China, uh, unlike China, we have plenty of clinicians. I think it's fair to say shortages in some areas, but our healthcare is just so incredibly expensive, and this would lower the cost. Um, the best example of a traditional provider, I think, with regard to AI is Mayo Clinic, um, which you probably know has several different branches headquartered in Minnesota. They have a very broad approach, but somewhat decentralized approach to AI. Um, some production applications in radiology and cardiology. I think they actually have a spin-out company based in Cambridge, Mass for the cardiology use case. A lot of administrative AI, as I will argue, if you want to be successful today as a provider, you're probably better off with administrative AI. They match patients to clinical trials. They have a close partnership with Google Health for kind of storing all their information and helping them analyze it. They, like many companies, have established what they call an AI factory to speed up machine learning. So it has a lot of reusable features and data sets and so on. Um, they developed a separate business. They brought in a guy named John Halamka, who had been the chief information officer at Beth Israel Hospital in Boston to head this thing called Mayo Clinic Platform to accelerate their digital transformation in a whole variety of ways, including investing in startups. And AI is what most of those startups do. The head of data and analytics for Mayo Clinic is, I think, a very strong believer in this idea. We're trying to enable more activities. A lot of people talk about governance. This is a more positive spin on governance. They have 50 or 60 people who go around the organization and help them generate all sorts of AI related activities. Although one of the challenging things I think about Mayo Clinic is you talk to many different people at Mayo, they'll say, yeah, I'm in charge of AI for the organization. So a little bit of confusion maybe about that decentralized approach to AI. Okay, so those are examples of organizations that are all in. Um, when I did this research, as I say, these three categories of AI objectives, Ping An Loblaw, a big grocer in Canada that is also increasingly a healthcare provider through its pharmacy acquisitions and so on, was one example. And Sampo, which is a Japanese insurance company, but um, a large, second largest operator of nursing homes in Japan, and has partnered with, they're a joint venture partner with Palantir um, in Japan. You may know Palantir, very commonly used in the US government to integrate data. They use Palantir to integrate data across nursing homes and then to create AI applications to identify patients in, need of attention or help. Mayo Clinic is an operational transformation category company. Kroger, of course, a grocery store chain in the United States, the largest one, trying to get more into health and nutrition related product recommendations. I mentioned Elevance Health, which is trying to create some new behaviors in terms of the nudges that they provide. Manulife is a Canadian insurance company that, like several other companies, including Ping An around the world, will, give you a fitness tracker and tell you, how many steps you're getting, and trying to move people into more healthy um, behaviors. And the only non-legacy company we looked at in this study was a startup called Well, started by a friend of mine. He used to be the CEO of Caesars, a big casino company. He decided maybe after helping people lose their money with gambling, he would help them improve their health. And this, again, is like one of the companies that Elevance acquired. It's a sort of behavioral change company relative to healthcare. It's doing quite well, so to speak. Okay, so healthcare, you can't really see it so well, but this is a woman pulling a fax off of a fax machine. And sadly, faxes are still quite prevalent in US healthcare. Why is it the case that we read so much about advances in healthcare AI, but we don't see it at the bedside yet? Well, clinical adoption has been slow, I think it's fair to say. FDA has to approve AI-based software medical devices, as they're called, and that slows things down. There are, I don't know, several hundred now, but the fact that even the FDA approves them doesn't mean they're in wide use. Payers have to agree to reimburse their usage, and that's been a sticking point. Um, Fitting into the clinical workflow, as I suggested earlier, has been a bit of a challenge. Basically, um, electronic health record systems drive the clinical workflow for many clinicians, and AI is not yet very well integrated into electronic health record systems. Um, uh, Physicians in many cases don't really understand how AI works, and so they distrust it and they don't use it in many cases. And as I suggested, EHRs are slow um, to add these capabilities. So as a result, as I suggested earlier, if you want to be really using AI in a provider organization, or payers for that matter, you're probably going to be more successful with administrative AI. We spend about 30% in our US healthcare system on administrative expenses, so there's plenty of room for improvement. There are AI systems that will call in, and providers that will call payer AI systems and say, where's my reimbursement? So, I think there probably are better ways than calling over the telephone, but at least you have automated voices on both sides. There is a company, an EHR vendor, that developed a system for extracting data from faxes. Again, I'm not sure this is the way we should do things, but if we're going to use faxes, it's probably not a bad idea. There are clearly some bright spots in AI in healthcare. I think precision medicine for cancer care is probably the brightest of them, the furthest along. If you are unfortunate enough to get cancer, you can get your blood or your tumor sequenced by companies like Foundation medicine and so on in Cambridge, and they will give you AI-based recommendations on what drugs might be suitable, what clinical trials may be helpful. Um, it's primarily oriented to oncologists, but it helps patients as well. Um, and data sharing, of course, is still challenging across the industry. We saw during COVID, we had horrible data sharing, and you had organizations like the New York Times and Johns Hopkins University and so on that said, we'll provide data on how many people are getting COVID and dying from it and so on, because and, they would call around to every state health department. It was really, really quite crazy. Even in the county level, in some cases, we had different approaches to measuring deaths and illness from COVID. So, the other side of this is all of the opportunities. I mentioned personalized medicine, and I think that's number one. Personalized diagnoses and treatments with generative AI, I think is on the horizon, not really with us much yet. Drugs designed with AI, that's starting to happen. There are a couple in clinical trials now, pretty advanced stages of clinical trials that were designed with AI, and I think we'll see a lot more of that. More effective and efficient clinical trial design, so we don't have to recruit as many patients and they don't need to last as long, and we don't have to give people placebos. Um, Dynamic models based on streaming medical device data that says, you better intervene with this patient. They may be at home in many cases, but we stream it in and say they need attention. Surgical robots have thus far not been terribly intelligent. They do provide, straight cutting and better vision and so on for surgeons, but I think increasingly they will do autonomous surgical operations, and there have been some trials of that. Sharing of data, not only to improve transactional tracking of patients, but also for training machine learning models is starting to happen. Substantial improvements in clinician effectiveness and productivity. We know clinicians spend way too much time on administrative activities, and so that's already starting to change with the advent of AI in clinical clinical workflows. And as I mentioned, things like that ping and good doctor systems, intelligent telemedicine systems. In China, they're talking about AI hospitals even that are not really staffed by humans at all. And they have a couple of trials of those. So we don't have anything that I know of like that in the US at all, but perhaps it'll come at some point. Um, one of the key questions, though, is how will AI interface with human clinicians? And um, we've seen, some challenges in this regard thus far. I think it's um, companies like Google are trying to develop language models that will provide diagnosis and treatment approaches for patients. And I think in general, this is a fantastic idea. I also think it's a fantastic idea to be conservative about releasing it to the world at large. But it's interesting, even though now this system, which was called MedPalm 2, now it's called MedGemini, Google has a bit of a problem with I think it's AI branding, but they say, this is a safety critical domain. We still need considerable further research before real world application can be considered. And that was 4 years after they have initially developed MedPalm. And already MedGemini is better than the vast majority of physicians. So I think, it might be time to loosen the reins a little bit in that regard. Um, uh, Penetration of AI in the US radiology market is still quite low. A recent study from a professor at Harvard Medical School suggests in the New England Journal of Medicine. There was an MIT economics department paper last year suggesting that AI systems for diagnostic radiology, which is one of the furthest along areas for AI, the AI systems working alone are better than when you have physicians and AI systems collaborating with each other, which is, kind of a bit discouraging because many of us thought the partnership of clinicians and AI was going to yield the best results. But the general feeling by the researchers in this study was that clinicians in many cases don't understand AI. They doubt whether it's valid or not, and in many cases they don't use it well. So you're really better off with just the AI, according to this research. There's a woman named Sarah Leibovitz, whom I haven't met, but I'm going to meet in a month or so. She's at the University of Virginia now, where I'm a visiting professor. They looked at radiology adoption of AI in three large New York City hospitals. And in only one of the three did the radiologists really adopt AI to a substantial degree. And that was again because I think that was in breast cancer oriented radiology. But in the other areas, they just didn't understand it. They, could see on the as in this picture here, a potential lesion identified by the AI system saying, this is likely to be cancer or whatever. But they didn't trust it, so they didn't use it. So even though they were mandated to use it in those three hospitals, in a big study in India, physicians were very worried about how AI would lead to lack of human supervision or employment loss, or that they'd rely so heavily on AI they'd lose their clinical skills. All sorts of human issues there. Now, in generative AI, we're starting to see, I won't go through all these companies, but we're starting to see some all-in types of adoption where companies are making big bets. Maybe you saw Coca-Cola's holiday ads. They were not terribly well received, but at least once people found out they were made by AI, they were not as well received. McDonald's is investing a lot, Toyota in product design. Morgan Stanley and Novartis have done great things with managing their internal knowledge. We see it in some law firms and communications, R&D. Sanofi, the big pharmaceutical firm, has said they're all in on AI. I told them I love that term for developing new drugs, code generation, of course, and as a front end to all sorts of analytical systems. But in healthcare, although I think healthcare is one of the industries that is likely to eventually be transformed, again, it's been fairly tentative adoption. I think education, including Ivy League schools like Brown, are going to be transformed, and journalism and law firms and marketing and advertising. Healthcare definitely falls into that category because it's a knowledge-based industry, and generative AI is really good at, generating and making accessible the knowledge that an organization has. But we are seeing some applications of generative AI. The one that I mentioned by my PCP, my primary care physician, I visited him for my annual checkup, and 5 minutes after leaving his office, I had the clinical notes from the visit, which is pretty amazing. It's because, of course, he told me about this and we talked about it. In fact, much of the visit was devoted to talking about AI. My wife said, "Why don't you just talk about your health or the lack thereof?" But it will draft up clinical notes, and of course, the physician should look at it and say what he or she thinks and make some edits here and there. Given that I had them within 5 minutes after I left the office, I'm not sure how much of that editing was taking place. That relies on patient visit conversation capture, of course. So you have to turn the speech into text and then make sense of that text in clinical notes. And I thought this was a sort of unalloyed good thing, but I must confess that yesterday, new issue of the New England Journal of Medicine, which I don't read all the time, but I try to read all the things that come out related to AI. A couple of physicians were arguing that, yeah, well, this clinical notes thing, it's probably not great because over time it's going to reduce the quality of electronic health records. And, I personally am not sure that that's true, but it's something that we would need to kind of monitor and make sure that it doesn't happen. Some people argue that the ease of creating clinical notes with AI will make for too much text in electronic health records, and then other physicians will say, well, summarize this, and then you're doing summaries of summaries and maybe lose some quality over time. Um, Physicians are composing emails to patients with AI. Medical coding was already using AI, but generative AI has made it better. You know, we have all these ICD codes, and it's impossible for humans to keep track of them. So I think this is generally a good thing. Still, I think most people believe that human oversight is better. As I said, some of these companies are doing personalized health nudges using kind of ideas from behavioral economics. Both sides, payers and providers, are using AI for prior authorizations. So it's kind of a war between the two sides, which AI will be more powerful. Clinical decision support, if you know anything about that field, been in use in electronic health records for a long time, but it's been rule-based, and rules they have some advantages. They're very easily interpretable, but they are rigid. They don't use data. They're based on talking to human experts. And eventually, I think we're going to get machine learning and generative AI into clinical decision support. Now, apparently, a lot of physicians are using generative AI for clinical decision support, but surreptitiously. In the same way, my doctor said, I used to consult the Merck manual. Now I consult ChatGPT. For better or worse. And as I say, in places like China, you have triage and diagnosis and treatment recommendations with generative AI and analytical AI as well, but not too many other places. So it's important to realize we're just getting started with generative AI. Last year, when I did a survey with AWS, not of all organizations, not just healthcare, only 6% had production applications. That's getting now to in the 20% range, but still pretty small. A lot of people have to change their data, start managing their unstructured data. Hardly about a third say I have the right data foundation to do generative AI well. You can look at this report um, uh, if you want to see more detail about that. Last slide. It's important, I think, to think big about how AI is going to transform healthcare if you're a provider or a payer executive, but you probably want to start small, particularly in the clinical space. You can go all in, and you should be using AI to do something new, but starting with administrative use cases, it's conservative. You might experiment with clinical applications, but the ones that are production now are probably going to be administrative. You should be experimenting with generative AI, agentic AI that actually does things and doesn't just, respond to prompts with replies. Certainly that would be for administrative applications. You don't want automated treatment of patients yet. Think of this as augmenting humans, not replacing them. Jeff Hinton, who won the Nobel Prize for Physics because of his deep learning research, even though he's not a physics guy, said, AI is going to be replacing radiologists within 3 years. He said that 7 or 8 years ago. I think it's fair to say it hasn't replaced a single radiologist. It's becoming an augmentation capability, which is the way it should have been all along. We will have to redesign work and workflows for the combination of smart humans and smart machines working alongside each other. And somebody should be in charge of this within your organization. Again, whether you're a payer or a provider, even I think for medical practice or something, this is too important to ignore. So with that, I will stop, and hopefully we have some comments and questions to address.
Hi, everyone. I know you're eager to get to the Q&A. We have a ton of questions, and please keep putting your questions into the Q&A. In the meantime, I want to quickly launch a poll and just do a quick poll before we get to the Q&A. So if you would please take a few moments just to fill this out, we'd appreciate it. I can read them for you just so you can track yourself. What is your primary goal for enrolling in an AI course? This is a single choice. To advance my career, to change jobs, to excel in my career. So please make one choice there. For the second question, What are the top AI competencies you want to learn? Please check all that apply. There are multiple choices here. Business strategy and operations, digital health tools, including wearables, ethics and governance, human AI collaboration, medical diagnosis, predictive analytics in healthcare, programming, prompt engineering, and technology fundamentals, ML, deep learning, NLP. And our final question is, how likely would you be to enroll in a 3-week, 6-session course on AI and healthcare at a price point of $2,000? Single choice, extremely likely, likely, neither likely or unlikely, unlikely, or extremely unlikely. So let's take a few more seconds. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Thank you so much. I'm going to end the poll now and turn it over to Sandy and Tom.
They'll be writing in, I'll pay more if that Davenport guy is not involved. So
No,
I
I
don't
don't think so. You've been terrific in your exploration here of all the things that are happening in AI and healthcare specifically. So thanks so much for that. There are some great questions in the chat or in the Q&A, so keep those coming. We'll explore as many as we can in the time that we have remaining. First, a couple specific questions came in about Ping An that you mentioned, the Chinese company. First was, what's your thought on why they've been able to become so much more advanced in the type of services that they're offering? Is it something to do with the regulatory environment in China, digital adoption by Chinese citizens? Like, what's going on there?
Yeah, great question. I think it's sort of all of the above. Ping An has put a lot of work into it. They've done a great job of assembling a human ecosystem to accompany this, smart is basically a smartphone app. I saw somebody else was asking what's the interaction model. They work with delivery companies on the prescription side. They work with pharmacists, et cetera. So they kind of put the human infrastructure together. I wrote an article in Forbes and in it's also a chapter in a book, but the article in Forbes is about the introduction of Good Doctor into Southeast Asia, and it talks some about how they made it work in that set of countries. The China one had been done several years before, so they just did their homework. It's not, I mean, it's not as big a business as you might think. It's about $1 billion in revenue now, so I think there's plenty of room for growth. There are 41 million paying customers, and as I said, 400 million that use it in total.
Interesting. So you did address partially what the patient interaction model is. Can you tell us a little more about that in terms of what you know about it?
All smartphone.
Interesting. So there's a free version versus paid version.
There's a freemium, I guess, is the business model, right? So I don't think the free version gives you much. It's kind of like a symptom checker, I think, and then the paid version connects you with physicians and all that stuff.
Interesting. Well, let's take a step back because early on in the session, we had just a basic question about could you provide some definitional opportunities around, what do we mean by AI? And then you sort of launched into sort of what generative AI and sort of what's the distinction that you make between those two things?
Yeah, well, AI in general is technology that does things that were previously only possible with the human brain. It's not a perfect definition. There is no perfect definition, I don't think, because there's some things that AI does that the human brain never could have done, like churn through massive amounts of data in a short time. There tend to be in healthcare, you see 3 different forms of AI. As I said, in clinical decision support for a while, we've been using symbolic or logic-based AI in the form of rules. And as I say, rules have their virtues, but they don't tend to scale all that well. When you get lots and lots of them, they start conflicting with each other, and they're not data driven. But the cool thing is you can look at them and see what's going on, and physicians like that. The second type is what I call analytical AI. I wrote a Harvard Business Review article about this with Peter High about analytical versus generative AI. Everybody's talking about generative now, but we didn't want people to forget there's a form of AI that's been around forever and still incredibly useful. And it's sort of, some people call it traditional machine learning, but it's using structured data, rows and columns of numbers to predict in the future, to predict rows and columns of numbers. So, if you want to decide whether somebody is likely to get diabetes or not, or whether a particular cancer medication is likely to work on a patient, that's analytical AI. Um, if you want to send them information about how to, manage their cancer or their diabetes or whatever, that's personalized to them and so on, well, that's where generative AI comes in. It generates text and images in many cases. It can make sense of images too. It can read graphics fairly well now. That was one of the problems with IBM Watson. It couldn't do that. But I think we're going to see combinations of all of those things, and particularly when now people are talking about agents and agentic AI, because generative AI has this tendency to hallucinate, to give you bad information sometimes to try to satisfy your prompt. So we'll probably see some degree of symbolic AI or rules in at least the orchestration engines. The other area that those rules and symbolic AI are present is in robotic process automation. And I think some aspect of that may end up orchestrating, when different agents go off and checking them and so on.
Interesting. So I think that gets at some of the risks. I'm seeing a theme in a lot of the questions in terms of, sort of what are some of the risks and downsides, particularly in healthcare. I think about what a litigious society we are, and sort of how can healthcare organizations or companies that are sort of going all in on AI really think about the governance so that they're sort of mitigating that sort of malpractice risk?
Yeah, great question. The leading approach to ensuring, ethical, effective, safe AI is to automate it to some degree, because if you have lots and lots of AI use cases being developed across an organization, it's going to be very time consuming for humans to examine them all and so on. There are, both in healthcare and in other industry sectors, there are programs that will go through, look at your proposed use case even before it's developed and say, I think you might end up having a HIPAA issue with this particular thing. Or Mayo Clinic developed a semi-automated review of their use cases to make sure that no privacy issues are violated. And I think at the same time, you're not violating HIPAA regulations. You have to make sure that it's going to be effective, because as you say, if it's ineffective, you may run the risk of malpractice suits or something like that. So I think there are two ways to avoid that. One, you very carefully test it. There was a fairly well-known incident where one of the leading electronic health record providers, Epic, produced a sepsis algorithm, sepsis prediction algorithm. Turns out it wasn't very good. And so I don't know. I think it was probably taken off the market before anybody sued them for it. But you have to test these things quite carefully. And that's one of the reasons why Google is being very careful about releasing Gemini to the public. You have to make sure that it's really good before you release it. And then you have to make sure that there's a human involved. If for no other reason, we need to figure out who to sue. So the human has to review it, I think, before signing off on it. And this is what they do even at, Ping on Good Doctor. They make a recommendation to the doctor has to accept or override it. Yeah.
Interesting. Interesting. Great. So a really interesting question early on talked about the importance of organizational culture. And I think you alluded to that in terms of how we change our thinking about the nature of work in working alongside these AI tools and models. And so in particular, how can healthcare organizations build a culture that embraces AI and data analytics?
Yes, no, I hate questions like this that go back to previous books that I've written, but no.
Well, he did reference that, so.
Nathaniel, I'm no longer responsible for things that I wrote that long ago. No, just kidding. I think there are a variety of ways. I think it's a multi-factor sort of initiative to create a data-oriented culture and AI-oriented culture. One, leaders have to set an example and use data and analytics and AI to make their own decisions. They have to reward and promote people within their organizations who take that approach. You have to have kind of a marketing approach to tell other people in the organization what's happening in that regard and kind of play up the successes. And, all of these systems are based on statistics, they're based on probability. They won't always work out. So I think people can learn from those as well. But in healthcare, uh, people are slow to adopt some of these new approaches. Harvard Medical School didn't establish a informatics department until I think about 5 years ago, when clinical informatics have been around for 50 years. So I think establishing roles within the organization who deal with data science and so on to help the rest of the organization will go a long way as well.
Excellent. So many great questions in here. I want to address healthcare organizations, particularly in the United States, we already spend the most of any sort of society on the planet in terms of our per capita spending on healthcare, and hospitals in particular, but many organizations have difficulty in adopting advanced technologies because of the expense. And so I'm wondering, and this was brought up in one of the questions about, sort of variability in adoption based on these, sort of ability to make technical investments given the sort of the financial environment in our healthcare system.
Sure, and to hire expensive people like data scientists and so on as well is an issue. But I think some of these things, particularly the administrative AI, you can do on a pay-as-you-go basis, because if you're using AI, for example, to get better usage of your surgical centers, of your operating rooms, and so on, that can save a lot of money. If you're using it to predict what inventory levels you need of key supplies and so on, that can save a lot of money. All of that is more analytical AI. Using it, I think, for taking clinical notes returns a lot of time to physicians. Um, we've jammed in more and more patients to physicians all the time. I think the average time spent with a patient is about 7 minutes or so. Maybe you don't want to just throw on more patients when they don't have as many clinical notes to draft, but you can maybe add a few, and that's going to increase revenue and maybe pay for the system in the longer run. So there are ways to save money with this technology too. And if your healthcare organization doesn't have a big budget for capital expenditures, I think you just have to demand that it pays for itself over whatever time horizon you can afford.
Right, and I think folks who are in the midst of proposing these types of tools need to really do that analysis. And
Yeah, and that's why even though it's a little boring, that's why I say you might want to start with administrative uses of AI, because A, it's more likely to pay back, and B, you're more likely to put it into production quickly. The clinical stuff just takes a lot of regulatory hoops to jump through, and it's got to be perfect. You don't want to kill a patient because of it.
right, exactly. So sort of an interesting question, rather than sort of direct patient care, what are your thoughts about applying AI technologies for public health surveillance, population health, vaccines, preventive medicine, contact tracing, things like that, we in particularly in the United States haven't made tremendous investments in public health structures. But what's the opportunity there?
But doesn't the questioner know that we don't care about that anymore, Cindy? Sad, but we do seem to be de-emphasizing that. We did it really badly during COVID. There were some other countries that did it much better than we did and had lower death rates, substantially lower death rates from COVID, South Korea, Singapore, et cetera. So a lot of that stuff is not necessarily AI based. It's more transactional technology, but still, I think using digital capabilities for public health is really important. And we can start to do a better job, I think, of predicting. A lot of the people who objected to COVID objected to, the lockdowns of everything. We can do a better job of predicting who's likely to be harmed by it and who's likely to get it, to contract a particular virus or disease, in order to manage the shutdown process a little more intelligently.
Mhm. I do remember during COVID, there were quite a few, state-based things that were sort of apps to do self-reporting and things like that. And there was a lot of sort of mistrust of those types of data tracking, the government tracking me kind of thing. So it seems like we have some cultural hurdles to overcome in that space as well. But
don't get me started on that, Sandy.
yeah.
Yes, we do. And we should not be managing epidemics on a state by state, county by county level. It just makes zero sense. But anyway,
Yeah.
much
Yeah.
bigger issue than we'll address here. Yeah.
Yes. And I will say we have some amazing additional questions in the chat here. So would love to continue to engage in the conversation, and perhaps that's another opportunity for us to talk again in the future. And we really thank you for your time and expertise that you bring to the conversation.
Thank you.
Thank you so much, Tom. Thank you, Sandy. This was an incredible presentation. I'd like to ask everyone to visit our website for more information about our programs. And also, I hope to see you back here on April 30th at noon to hear Ed Barrows talk about building emotional trust. Thanks so much, everyone.
But thank you.